Imagine waking up and finding your loved one's dressing soaked, and no one has shown up. A week after discharge, Mrs. Alvarez's daughter called me frantic. The dressing was soaked, a red streak appeared up the arm, and the agency had said they would be there that morning but didn't come. She didn't know whether to call 911, the nurse line, or the primary clinic. That's the kind of panic we can prevent with a few simple habits. Today, I'll give you the language to use, the checklist to prepare, and the red flags that mean call for help. Let's separate medical fact from fiction and make home care safer and less stressful.
So, what is home health? In short, it's skilled clinical care delivered at home for a defined medical need. Think nurses, therapists, aides, and a case manager who coordinates care.
Registered nurses do assessments, wound care, IV antibiotics, and teaching. Licensed practical nurses often provide routine skilled follow-up. Physical and occupational therapists focus on mobility, strength, and safe transfers. Speech therapists help with swallowing or communication when needed. Home health aides help with bathing and personal care only when ordered. Each role is specific and limited to what is authorized. People often mix up home health with home care. Home health is clinically driven and ordered by a clinician, short episodes of skilled care. Home care or personal care is non-medical help, like meal prep or companionship, and is usually arranged differently. If you're leaving the hospital for wound care, IVs, or therapy to avoid readmission, that's home health. Who qualifies and how does a referral happen? Usually a hospital discharge planner, your PCP, or a specialist sends a referral with an order. Medicare requires a physician order, intermittent skilled care, and that the patient be homebound. Private insurers and Medicaid have different rules, so expectations must be realistic. If you're unsure why you were referred, ask directly. Why am I being sent to home health? That short question models what to say and often clears up confusion immediately. Here are exact intake call phrases that work. Say, "Hello, I'm calling to check the status of a referral for Jane Doe, referred by Dr. Smith for wound care and PT. Can you confirm whether services are authorized and when the first visit is scheduled?"
Hello, I'm calling to check the referral for Maria Sanchez, referred after discharge for wound care. Can you confirm the first visit date?
Back to me. Short, specific language like that reduces hold time and gets the person on the line to look up your file faster. If you want less personal detail on a public line, say, "I have a question about eligibility. Who can I speak with?" Let's walk through the first visit so you can picture it. The nurse will introduce themselves, confirm identity and consent, take a focused history, check vitals, inspect wounds, reconcile medications, assess mobility and fall risk, and review safety in the home. Expect teaching, documentation, and a written plan with follow-up timing. Quick tip: have a medication list or pill bottles, your ID and insurance card, discharge paperwork, and a list of current symptoms ready. Clear a small table near good light for the clinician to work on. You can say, "Today I need teaching on the wound dressing, confirmation of the medication plan, and help with transfers." That helps the nurse prioritize what matters to you. Teach back is your best friend. Ask the nurse to show you once, then watch you do it. Say, "Please demonstrate, then I'll try it and you can correct me." When patients do this, mistakes get caught early, and everyone sleeps better. I'm going to show you how to change this dressing. Patient, "Okay, show me, and then I'll try it." That short exchange is enough to create a safe learning moment. Medication management. Ask for a reconciled list and a simplified schedule. If multiple meds are confusing, request a pill organizer or a blister pack through the pharmacist. Therapists, ask for measurable goals, not vague ideas, but something like walk 10 steps with a walker in 3 weeks. Equipment and safety. Request durable medical equipment early, hospital bed, walker, commode, and ask the case manager who orders this and how long will it take. Remove throw rugs, ensure good lighting, and have non-slip shoes available. Now, the red flags, short and direct. If someone has severe shortness of breath, chest pain, or loses consciousness, call 911 immediately. If you see fever plus a fast heart rate, low blood pressure, confusion, or a spreading, very painful wound, those could be signs of sepsis. Call for urgent help.
For urgent, but not necessarily 911 level problems, new foul drainage, a leaking or painful IV, sudden uncontrolled pain, or sudden changes in thinking, call your nurse right away and document the call. Say, I have a potential infection concern and need help deciding if this is urgent. That phrase helps clinicians triage with you.
Documentation matters. Keep a brief log with date, time, symptom, what you did, and who you called. Example, 4:12:10:15 a.m., increased drainage from right leg wound, called home health nurse, left message. This helps clinicians make faster decisions and protects you if there's later confusion.
Billing. Ask the agency before services start. Are services fully covered? Are there copays? Who will bill me? If the answer is vague, request a written estimate and speak with their billing department. Keep a note of every call and who you spoke with.
Common pitfall, assuming unlimited visits. Orders are often time-limited. Another, assuming aides are covered when only skilled nursing is authorized. If you get a surprise bill, call the agency billing office, then your insurer's appeal line, and document every conversation.
What if an agency misses visits or care quality is poor? First, ask to speak with the supervisor or clinical manager. Describe who, what, when, and the resolution you want. If that fails, contact the referring clinician or discharge planner. If needed, file a complaint with your state health department or licensing board. I know it's extra work, but keeping notes usually gets faster resolution than waiting.
A quick real example. Mr. Lang missed a first visit because authorization wasn't verified. His daughter used a short script to the agency billing team. Can you confirm authorization and the expected first visit date? And got the issue escalated the same day. Small scripts prevent big problems. 2 fast FAQs I hear all the time. Q. Will my home health nurse empty my catheter or change a complex dressing? A. If it's ordered and within the nurse's scope, yes, but ask for a demonstration and documentation so you know what's covered. Q. Who replaces supplies? Often the agency supplies dressing materials during ordered visits, but confirm who provides and replenishes supplies before they leave.
Mythbusters. No, home health nurses can't do everything a hospital can. They provide intermittent skilled care. No, a single Medicare denial doesn't always end services. Appeals and extra documentation help. And please, ask questions. Teachback and written plans are your rights as a patient.
3 clear takeaways. 1. Home health is skilled care ordered for a medical need. Ask for a copy of the order. 2. Prepare for the first visit. Medication list, discharge papers, good light, and a short list of priorities. 3. Escalate early and document everything. Call 911 for true emergencies, your nurse for urgent clinical concerns, and supervisors or your clinician if system problems persist. Final printable checklist you can speak aloud right now. 1. Current medication list, insurance card, and discharge orders. 2. Ask the agency, who is my primary nurse, when is the first visit, and what's authorized. 3. Request teachback for medications and wound care. Watch and then do. 4. Keep a symptom log and document calls. 5. If in doubt about infection, breathing, or severe pain, call 911. Keep this where caregivers can see it. Remember, this episode offers general guidance. Local rules and payer policies vary, and nothing here replaces individualized clinical advice. If you need site-specific answers, ask your agency or clinician, and check the episode notes for links to Medicare and state resources. Thank you for listening.
If this episode helped you feel more confident arranging or managing home health, that's exactly why I make this show. You can find episode notes, printable checklists, and links at FAQbynursejessicaconsulting.com. Please subscribe so you don't miss future episodes, and if you can, leave a review. It helps others find reliable information. Until next time, stay informed, stay compassionate, and always put safety first.